Lovely. Thank you, Alok. Let's crack on with the session now. We'll talk about the abnormal lung again, and there will be a lot of repetitions of what we have done before. In my previous session, we talked about pneumothorax pneumonia. We're going to talk little more about it today, and I'll do less of the theories today and more of image practice slides. Basically, we'll see different images, and we'll try to make it a more involving session today. So the abnormal lung. And what are the objectives today? So we'll recap a bit, not in a conventional way, but there will be a lot of repetition of the same signs, so that we see these things again and again, and we can consolidate that in our memory. We'll talk about pneumothorax, pneumonia, a little bit about pulmonary hemorrhage, and then we'll have some practice slides, and we'll do some Q&As at the end. Ehrlich's. We have been diagnosing pneumothorax for last couple of decades with the use of chest X-ray, and now what's new we're going to do with the lung ultrasound, or why we are using it, is because it's superior to chest X-ray in diagnosing pneumothorax. There has been a lot of publications about it from the adult emergency care medicine, and also from the neonatal studies. That lung ultrasound is superior to chest X-ray. How superior? So chest X-ray is 75% sensitive in diagnosing it and 100% specific. So when you say it, it is there. But if you don't say it, 75% of the time, you're right. 25% of the time, you're wrong. Whereas lung ultrasound is 98% sensitive and again, 100% specific. So we can see a very, very minute pockets of air as well with the lung ultrasound. What we're going to do about it? Probably nothing. But we do not miss pneumothorax with the lung ultrasound. If our technique is proper, if we are looking at all the areas of the lung. So yes, 98% sensitive and 100% specific. Now the question arises, can we quantify Ehrlich's? Well, the answer to that is yes and no. Yes, we can quantify grossly, and that's a yes as an answer, and no, because sometimes it becomes very tricky, and you cannot give an absolute number, or do we need to put a chest drain or not in looking at the pneumothorax on the lung ultrasound. So you have to take into account the clinical condition of the baby as well. So can we quantify Ehrlich's? No, in that case, because it will it'll be really difficult to quantify the volume of air with the lung ultrasound. Talking about the evidence, so you can see there are a lot of papers have come up. It says the overall sensitivity for the lung ultrasound is 78.6 to 100%. And specificity is 96.5 to 100%. This is at the beginning of when we started doing it, and as these studies kept on adding on, the sensitivity we can safely say is around 98% now. And there have been meta-analysis in Cochrane, and all the New England Journal of Medicine, Association of Anesthesists. I haven't put all the papers' name here, but trust me, there are a lot of papers which talk about the same thing. So it's unequivocally more sensitive. Now, because lung ultrasound was at infancy a couple of years back and still a baby at this point of time, and as with all the new modalities of diagnostic medicine, there is always a little bit of a pushback or a resistance from our colleagues. So we needed something from a global body to accredit it as a proper way of or proper modality to be used as a diagnostic tool in babies. It has long been established in the adult medicine, but that's a completely different ballgame in babies. So we needed some global body to accredit it. So ASPINIC, the European Society of Pediatric and Neonatal Intensive Care, all the grown-ups have had a roundtable conference and gone through all the evidences that has been there at that point of time, and have come up with the recommendations of point-of-care ultrasound, which is inclusive of lung ultrasound. And it talks that it's accurately detect pneumothorax in neonates and children. So there you go. We have a strong agreement, a consensus from the ASPENIC that it works, and the level of evidence is B. Now, mind you, this was a couple of years back, and we have a lot more studies which has been added. And I'm sure in the next session, whenever that would be from the ASPENIC, the level of evidence will move to A. The level of quality of evidence, what I mean by that is this, as it's been reflected on your screen, the A being high quality of evidence, where further research is very unlikely to change our confidence. You don't need many papers or research to prove that. It's already proven beyond a point. Whereas level B is a few more, further researches are required to sort of impact our confidence on its accuracy in detecting pneumothorax. So, and again, as I said, a lot more studies have been added after that. So I'm pretty sure that it will move from B to A in next session. Right. So what are the advantages of the lung ultrasound when we talk about detecting air leaks as compared to the chest X-ray? It is immediate. Chest X-ray, you have to, sort of request it, wait for the radiology technician to come handle the baby, to do 10 different maneuvers and finally get an X-ray, which again you have to wait to get it to your PACS system and then see for everybody on the screen and to say that, oh, there is a pneumothorax. Whereas with the lung ultrasound, it's the primary clinician who's looking after the baby. Have a doubt that, oh, there might be a pneumothorax with this baby. Suddenly the respiratory effort has gone up, oxygen requirement has gone up, or whatever. The baby is deteriorating, so why not we put a probe on the chest and have a look? So it's very immediate, and it's done by the primary care physician of the baby. So then it's very repeatable. You can do umpteenth number of time without worrying about the putting the baby as the risk of ionizing radiation multiple times. So as many times you can do it, and it is advisable to do many times, because that will be a serial ultrasound to see if it is progressing or improving or worsening. It is cost effective, and cherry on top, it reduces radiation exposure on the babies. And as Nadia has spoke yesterday, their unit in Paris, they practically don't use chest X-ray anymore. They do use only lung ultrasound in their neonatal units. So, so these are the advantages, but we have to be mindful of the fact that there are some false positive cases as well, especially.
Excuse me, Abhi.
Sorry about that. That's my computer. I'll just put that on mute. Yeah. So, about the false positives. So we have to be very mindful of the false positive scenarios, because when we are learning to do this, and, especially so because as I say, this was at infancy and now it's a baby, and we still have some resistance or pushback from the colleagues. So we don't want to be on the, wrong side of the team where we have said there is a pneumothorax, we do a chest X-ray and there is none. So, so what are the false positive? So if you have done a mainstem intubation, basically single lung intubation, your tube has gone way far in. On the contralateral side, there will not be any movement. So you lose pleural sliding on the other side, which is one of the signs. It's not specific enough, but that's one of the signs we talk about in diagnosing pneumothorax. So that's one. Blebs and bullae. Again, these are small pockets of air from the outpouching of the pleura. Because of, it could be spontaneous, it could be because of high pressures on the ventilator, but nonetheless, because lung ultrasound can pick up the smallest pocket of air, it's going to pick up the blebs and bullae, and it will give you a false impression that there is a pneumothorax there. Then if there is an emphysema in the baby, again, emphysema is outside the pleura. It's in the subcutaneous tissue, but it's because it's air and it's an enemy of ultrasound waves. So it's not going to let any waves pass through it. So it's going to give you a false positive sign of pneumothorax being present there. And also because you don't have pleural sliding, as we have seen the questions in the chat box, there is no pleural sliding in the pneumothorax. and in consolidated areas. So if you don't see, if you see actually, if there is a collapse or consolidations in that particular area of the lung, you're not going to see pleural sliding and might indicate towards pneumothorax. So these are the scenarios where you can have false positive, but we can work around it, and so that we don't diagnose falsely pneumothorax. And then where can we have false negatives? There is a pneumothorax, but we don't see it. Can it actually happen? Yes. If you have an inappropriate technique of doing it, then that's the only point you have to be mindful. So it's always an inappropriate technique if you fail to see a pneumothorax with a lung ultrasound. Now, I'd like to talk about this air fluid ratio curve. As you can see on the y-axis, there is air. As you're going up on the y-axis from the baseline 0 to 100%, and on the x-axis from the right side of the screen to the left, the fluid is from 0 to 100%. So 100% air is pneumothorax. So normal lung, there will be air and some element of interstitial fluid, which is normal, as you can see 2 to 3 B lines in a normal lung. So 99% air in a normal lung. As you progresses, interstitial syndrome, where the thickened septa, again, which going to give you reverberation artifact and B lines, and again, interstitial syndrome, where you have more of a B line and going near the compact B lines territory. Still, there is 95% of air there. As you come below the, go more towards the fluid part of it. So pneumonia, you lose aeration at that particular segment where there is a collapse consolidation or atelectasis. You can see in pneumonia, there is still 10% of air, which give rise to sort of a dynamic air bronchograms. It moves, keeps on moving with the inspiration and expiration. And also there is an air trapping there in pneumonia. Whereas in atelectasis, your air quantity comes down. Because there is no air trapping. Basically, the segment has collapsed because there was no air to begin with. So it is just 5% there. And the end of the spectrum is pleural effusion, where there is completely filled up with the fluid, that particular area, which is basically by the virtue of gravity on the basis of the lung. So that's the air fluid ratio curve. Diagnosing pneumothorax. So this is a diagnosis of air within the air, when we know that air is not a good conductor of the ultrasonic waves. So it's quite tricky. So again, it's all about the artifacts. So how we diagnose it. So all the signs and signs of the pneumothorax are absence of the pleural sliding. So you don't see pleural sliding. So pleural sliding is abolished in pneumothorax, and so are in the other pathologies as well. So this is not specific to pneumothorax, but it is one of the sign of the pneumothorax. Then you get an A prime profile, or you might choose to say it as an A profile. A prime profile, the word, that's terminology has been picked up from the Blue protocol, which has been devised by the colleagues in France. And this is from the adult emergency medicine. So A profile is basically A prime profile is basically absence of B lines and or comet tail artifacts. So you do not see any B lines or comet tail artifacts whatsoever. So absence of pleural sliding, and then you see A prime profile. When you interrogate that particular area with the M mode, which is the motion mode of the ultrasonic scanner, then you can see a barcode or a stratosphere sign, which is pathognomic. Now, if you see this sign, then you're 100% sure that there is air in that particular segment of the lung. And then lung point. So lung point is pathognomic again. So this is nothing but the transitional zone between the normal aerated lung, which is which will give you the pleural sliding, and there you can see some B lines or maybe comet tail artifacts. And then the others and the other transition to the area of pneumothorax, where you do not see pleural sliding and there is an absence of B lines or the comet tail artifacts. Right. So this is the sort of a the tree, diagnostic tree, when we think about pneumothorax. So you're approaching a baby with this, probe in your hand to answer the question: is there is a pneumothorax in this baby? So what do you look at? So you look at the pleural line. Is there is a pleural line? Yes, there is a pleural line. Then you talk about the pleural sliding. Is there is a pleural sliding? Is that pleural? Is that the parietal and visceral pleura is moving? So sliding against each other. So the answer to that would be either yes. So if the pleural sliding is present, it's done on my video. Right. So if the answer to your pleural sliding is yes, so parietal pleura, visceral pleura. So if your visceral pleura is moving against the parietal pleura, that's your pleural sliding. So if it is yes, there is no pneumothorax. Pneumothorax is air between the parietal and the visceral pleura. Yeah. So if it is there and sliding against each other, you do not have pneumothorax there. So if the answer is yes, no pneumothorax. And if your pleural sliding is no, it could be anything. So pleura is not sliding. So you don't know if actually there is a visceral pleura there or not. What you know at this point of time, it is not sliding, it's static. So what you look for then? Now you look for B lines. Is this static area which is not moving with the abolished pleural sliding, is there is a B line projecting from there? If your answer is yes, if there is a B lines coming, you know B lines are generated when there is fluid, interstitial fluid or fluid in the alveolus. Yeah. So if you have B lines, fluids in the interstitium or fluid in the alveolus, basically the lung is there. So if there's a blue line, no pneumothorax. If answer to your B lines is no, you do not see, it's not moving, no pleural sliding, you do not see B lines. So there is no B lines. So what it basically means, there is no alveolus, there is no interstitium. The answer is there is no lung there, there's air. Then that's pneumothorax. And then you try to look for the lung point. Now you might be able to see lung point if it is a small or moderate size pneumothorax. But if it is a large pneumothorax, you might not be able to see a lung point. If you see nothing like it, it's a pathognomic sign. And yes, there is a pneumothorax. And if you don't see it, but you have abolished pleural sliding with no comital artifacts or B lines, and you see a barcode or a stratosphere sign, that's a sign of a pneumothorax. That's the blue protocol I was talking about, and it has sort of given us a diagnostic tree of different lung pathologies, talking about pulmonary edema, pneumonia, and pneumothorax. You can see there is an A profile there. I don't know if you can see my cursor. Can anybody see my cursor moving over the screen?
Yes.
Yes, yes.
Okay, so so A prime profile. So again, lung sliding, abolished, A prime profile plus a lung point is a pneumothorax. Without the lung point, and you don't see a B, you don't see a B lines. Sorry, you do see a B lines there. Then you have to think of other modalities or other pathology. So these are the blue protocol profile definitions. So A profile is anterior lung sliding with A lines, which is normal. A prime is A profile, anterior lung sliding with A lines, but abolished lung sliding. B profile is again with the lung rockets. B prime, we don't talk much about B prime in neonatal, you go through all the literature, there's not been much mention about the B profile in the neonatal literature, but this is basically B profile with abolished lung sliding. And B profile with abolished lung sliding is not pneumothorax. That's something else. C profile is lung consolidation. And AB profile is when you see A and B profile in different lung zones.
Sorry, Abhijit, just one thing to mention, just the blue protocol. And when Dr. Lichtenstein made the blue protocol for the AB profile, just to clarify for our participants, it is different from the AB profile that we talk about, which is kind of A and B profile within the same fields side by side and or kind of transitioning lung. his intention was to talk about A profile, A dash profile in the right lung versus a B profile in the left lung. And it kind of, for an adult, meant a possibility that that person may have a mnemonic kind of, or a kind of a B profile secondary to pulmonary edema, as opposed to the kind of AV profile that we see in transition. So just a slight difference. Yeah.
Lovely. Moving on. So we'll see a lot of images today. I promise there won't be a lot of theory. Right. Anybody would like to comment on this particular right posterior two zone of the lung? It's about a question about pleural sliding. Can we see pleural sliding here?
No.
Excellent. So we cannot see pleural sliding here. So now commenting on this particular image here, we can see, the soft tissue of the chest. This is all the soft tissue of the chest. You can see nice clear ribs with the acoustic shadowing. You can see a bright, discrete, smooth, regular pleural line. And you can see A waves coming equidistant from it. But you cannot see any projections whatsoever from the pleural line. So there is no pleural sliding. Yeah. So A prime profile. Same thing. So you just see, as I've described just now, you do not see any cometal artifacts or lung rockets here. Pleural sliding is abolished, and you can only see A lines. Any comment on this particular one? RP1 area. Again, subcutaneous tissue, ribs, acoustic shadowing there. And then you see nice, discrete, smooth pleural line, no lung rockets or B lines here. It's all A lines coming up at equidistant. A prime profile again. So same again, I have zoomed into that particular area, and now what you can see is this is from the same baby, the last image you have seen. I've just zoomed in now. You can see a very nice, discrete pleural line, smooth and continuous. That's the subcutaneous tissue. These are the ribs. And then you can see the reverberation artifact, A lines, coming up equidistantly. And the artifacts which Sharif has shown today, the same thing. You can see the mirror image. You can see the mirror image on both sides of the pleura because there is air, it reverberates. The ultrasound waves is not basically passing beyond this point. It's just bouncing back to the probe. So it's giving you a mirror image artifact. A prime profile, no B lines, no lung rockets, and mirror image. This particular image, sorry.
You see some of the similar to be moving around. Would you not consider that a sign of sliding?
Sorry, I can't hear you properly. You're breaking up.
Okay. Like there might be a shadow of B lines which are moving.
Sorry, I'm so sorry. You're breaking up. I couldn't.
Okay. Can you hear me now? Okay, that's fine. I'll just type my question.
Would you mind just putting your question on the chat box?
Yes, I will.
Oh, I can hear you now. Yeah.
Okay. Can you hear me now?
I can hear you, but you're still breaking up.
Okay, sorry. That's fine. No worries. No worries.
Yeah. So where was I? Yeah. So this is a truck sign. If you can see the reflection of the rib on both sides of the pleura is called as truck sign. So mirror image of the ribs on the both sides of the pleural line is also known as a truck sign.
Dr. Abhijit, can you repeat what is truck sign?
So if you see this particular image here, so this is A prime profile, because you can see a pleura, but there is no pleural sliding. Why no pleural sliding? I don't see lung rockets and I don't see any B lines. Had there been any B lines, it should have been erasing the A lines. So no lung rockets, no B lines, but I can see A lines coming up. Yeah. Truck sign is when you see the ribs on both sides of the pleural line. So of course, you're going to see each time on the, ribs and the pleural line. But if there is only air, you can see ribs on both the sides of the pleural line. You see what I mean? So ribs there, again, the artifact, the mirror image here. This is the mirror image of the rib, this one.
Yep.
Mirror image of the rib. So,
Giving an image of 4 wheels or so.
Yes, so that's a truck sign.
Okay, thank you.
Whereas we can see a mirror image in the deeper pockets as well, as we have seen this on the last session. So your liver, diaphragm, and then because there is an air here, you can see a part of the liver on both the sides of the diaphragm. You see what I mean? So again, you can see the same vessel coming up and going here, same echo texture on both the sides of the diaphragm. So there is some air here. Normally, if there is no air, you should be able to see the blood vessels and the spine on this side. But here you are seeing just the liver on both the sides. So that's a mirror image when you have air pockets. Moving on to barcode sign or stratosphere sign. So again, the same baby, same area where you can see the truck sign. I have interrogated that with the M mode. And when you do M mode over the area of the pneumothorax, this is what you get. So straight lines, there is no sandy beach appearance. There is no granularity in this particular area here. There's no granularity. So it's all straight lines. And it looks, it's called as a barcode or a stratosphere sign. And we talked about the T lines as well today. So what are T lines? If you see this particular transitioning lines here, these are the lines. Right, so this one. So if you see these transitioning lines, so these are the cardiac impulses that has been transmitted to that particular area of the lung, of that particular area. So the scanner picks up this transmitted pulses from the heart. Because it is transmitted, it is called T lines. Very easy terminology. And the way to confirm that, you can see with the ECG of the baby, it comes with each heartbeat. Yeah, any question here? Lovely, moving on. Anybody wants to comment on this particular image? Yeah, Sharif, go for it.
Yeah.
Do you want to comment on this particular image here?
Yes.
This is an M-mode interrogation of the lung.
Again, I can, I'm not sure, the video is not playing, but what I can see that I can see some confluent B lines.
Yeah.
It seems to be, I can see A lines as well. It's AB profile. And in the M mode down there, I can see some, it seems like seashore sign.
Absolutely. So again, sky, that's the ocean, and that's the sandy beach. Yeah, so you can see the difference. The reason I have put it up here is to show you the difference. So this is the granular appearance. It looks very granular, hence the name of the sandy beach. And if you compare that with the next one, which is over the area of a pneumothorax, it looks like straight lines. if that makes things clear for you guys. So just to differentiate a sandy beach from a stratosphere sign. Yep. Lung point. So lung point is the most specific sign of a pneumothorax. It's pathognomic, like a barcode sign. This is again pathognomic. Lung point is also pathognomic for a pneumothorax because you can see lung, the normal aerated lung transitioning into the area where there is no lung, is only air. So this is what it looks like. And I will also try to, kill some confusion here. I can see people asking questions in yesterday Nadia's session about anterior, posterior, craniocaudal, where exactly the air is going. Is it not supposed to go up or anteriorly or cranially? So we'll tackle that as well. So you can see this is the cranial end, this is the caudal end, the anterior aspect and the posterior, as shown by my cursor here. So there's a normal aerated lung because you can see nice discrete pleural line, and these are lung rockets because this is not reaching the end of the screen. Lung rockets terminating somewhere here. You can still see the A lines. There are some B lines. Whenever they come up, it kills the A line here. So that's your normal aerated lung. Now, compare that to this particular area here, where you can see pleural line, but you cannot see any lung rockets or B lines. You can only see the A lines. So this is the lung point. So normal aerated lung. Sorry about that. Yeah. So this is the normal aerated lung. And here, where you can't see any lung rockets or the B lines, that's the area of the pneumothorax. So this particular area where it is transitioning is called the lung point. Right.
Wait, Abhi,
So,
can I ask you a question, if you don't mind?
yes.
The previous slide, I was just thinking because, sometimes it's difficult to appreciate the lung sliding. So maybe this point, I know that clinically is very important, but I'm just talking about this slide. So if you take the video, I can find that it might be difficult for me to appreciate on the right side that there is no pleural sliding. So I would think why this is a normal lung on the right side, because I can see A lines, but on the left side there is a bit of A and B signs. So maybe this is a lung point for a TTN, for example, because I can't appreciate the sliding of the pleura. So how can I differentiate if it's TTN or pneumothorax only from this slide?
Yes. So you interrogate with the M mode.
Okay.
Yeah. So if you are in a doubt or if you are not being able to make out 100% sure that is that particular area is sliding or not, because sometimes the impulses will also looks like, or because this area is moving with respiration, it looks like this area is also moving, whereas there is no sliding in this area. If you can compare, if you can compare these two areas with this one. Very valid question about the double lung point, because double lung point also looks similar to this. So you interrogate with that area, particular area with the M mode. You interrogate this area and you interrogate this area. Then you can see sandy beach sign coming up here, whereas you will get a barcode or a stratosphere sign over here.
Okay. Thank you.
Yeah. And again, lung point. Yeah.
I have again this similar kind of confusion that I had yesterday. So again, the pointer is towards the cranial end, and we can see the air towards the caudal end. So again, I'm confused. So I expect the air to be collected in the more cranially rather than caudally.
Understood. So I'm just gonna deal with that. Mayank, I heard the question yesterday. Yeah.
Okay.
Cool. So chest X-ray. So I mean, I'm not very good. I have a confession to make. I'm not a very good person when it comes to reading chest X-ray, but I can tell you very grossly there is an area of pneumothorax. Where is it? Come on. Yeah. So everybody agrees there? There's some air there?
Yes.
Yeah.
Yeah.
Yes.
Okay. Yeah. Right. So this is the area where, the pneumothorax is. Now, to answer your question, Mayank, and to anybody's mind that's, is being confused about where the air goes. So let's make this, chest X-ray supine. The baby is already supine. I'm trying to just make the chest X-ray supine so that it looks more like a lung ultrasound. Okay. Now the baby is lying supine, and you're going to do a lung ultrasound in the baby who has got a pneumothorax in this particular area. All right. So we're going to put a probe there. So with respect to this X-ray lying supine, this will be the anterior part, the upper part, because baby is lying. So upper part of the chest is anterior. That's the caudal end, cranial end, and the posterior. Everybody agrees there? Mayank, do you agree there?
Yep.
Cool. Now, let's see how we put the probe. There was some confusion about longitudinal, transverse, oblique, all sort of terminology. So when you put your probe like this, and there's a multiple ribs coming under the probe, this particular position is called longitudinal position, or you can say vertical. Yeah. And when you are doing it, with probe in this fashion, it's oblique, horizontal. Agree?
Yep.
So far, so good. Yeah. Okay. Now let's make this supine as well. So this is how we're going to do the lung ultrasound on this baby. Now that's your probe, and you are putting is longitudinally covering 2 to 3 ribs, so that 1, 2, 3, at least 2 intercostal spaces comes into the view. Yeah.
Mm-hmm.
Now, when you do that, mind you, this was the baby with a pneumothorax in the basal area and baby lying there. So you can imagine when you are putting your probe, longitudinally in this section. Okay. So you're going to see there is a rim of lung. Can you see the lung there? Because there is a lung markings. Yeah. So you're going to see some lung here on the cranial end, and on your caudal end, you're going to see air. Agree?
Yeah, I agree.
Yeah. So now moving on, this is the picture you're going to get. So anterior aspect, where the sternum would be, posterior, where the spine will be, cranial, you can see the lung there, and there's the area of pneumothorax.
Yeah, I can understand this situation, but most of the air leaks. So I would probably classify this as an air pocket, and most of the air leaks that occur pneumothorax large enough. So they would be kind of regularly distributed, to say. So they would not be located at a particular point. Like this is most likely an air pocket located at the lower part of the lungs, but an air leak otherwise would be distributed throughout the pleural space. In that case, I feel it should be collected more cranially.
Yeah. So if your air leak is big enough, so it's going to take the entire space, then yes, it could be everywhere in all the lung zones. But what I'm trying to tell you here is, if it is a small pocket of air, you can get this kind of a picture, where you can see the lung and the cranial end of it, which goes contrary to our conventional belief, because we do chest X-ray sitting upright and air goes up, and there you see. So we tend to believe like that. But when you lie down, it goes anterior. Now, if it is small enough, it could be anterior at the the mid area of the chest. In this particular scenario, the pocket of air is completely in the basal area. So you can see scenarios like this is my point I'm trying to make. So you can see areas. This is not always true. You might not be able to see a lung point if it is a big pneumothorax, or you can see it's in completely opposite direction. The pneumothorax coming on the cranial side, and the normal aerated lung here maybe. So you can see that. I'll show you images of those as well. So again, answering question to Dr. Sharif. So this is what I was talking about. So because you do not 100% sure that there is a lung sliding, or it happens to me as well. So I quickly do a M mode interrogation of that particular area. So first I did over here, which gave me a nice sandy beach appearance or sea shore appearance. Nice granularity. That's your sky, that's your ocean, and that's your sandy beach. And then while being in the same frame, I quickly moved my, the cursor to the area where there is a doubt, there's a pneumothorax, and you can see it's visibly very, very different. It's all straight lines. Do you agree now?
Yeah, that's very obvious. Yeah, thank you.
Yes.
Thank you.
Yeah.
Thank you.
Brilliant. So moving on, again, Mayank, this is a particular case we right now have in our unit, this baby. You can see the baby is already having a chest drain, and you can see a pocket of air there. Now we can have a number of explanations about why this pocket of air is particularly there. It's not rising to the, again, as opposed to the conventional belief, it's not going to the upper part of the lung. And it's big enough to sort of compromise the baby. This particular pocket of air we have to put in a chest drain. So you see what I mean. So in this particular baby also, if you do a scan, you're going to see the lung point because there is a lung here. So you're going to see a lung point, and you're going to see a pneumothorax, the transition zone here, cranocordially. Yeah.
Yes, I completely agree.
Lovely. I think that's that's about it about the pneumothorax. And as we do more, these are the signs that you have to be mindful, and always interrogate the area with the M mode to be 100% sure about the pneumothorax. And the pathognomic sign is always the lung point, which might not always be visible, but barcode or stratosphere sign will always be there. Now, moving on to the pneumonia. Again, lung ultrasound is superior to chest X-ray in diagnosing pneumonia. Again, it has been validated. Lung ultrasound sensitivity is 86 to 94% as compared to the chest X-ray, which is just about 38 to 76%. And you can very well by now understand why that's the case, because you can start seeing the consolidated area from the very beginning of it. Chest X-ray might not be able to pick up the consolidations in first couple of days when it is evolving phase. So hence such a low sensitivity there. Pneumonia always progresses through stages, and so are the ultrasound changes. So you have to be mindful of the fact that when you're doing an ultrasound, a pneumonia, because it goes through the, initially it will be start consolidating. So you might not be able to see a dynamic air bronchogram. It will be just a static bronchogram to begin with. Then eventually there will be a, slowly the A lines disappears, B lines comes in, there will be a shred sign, and it could lead to a full-blown hepatization, which is basically a tissue-like sign. It looks more like a tissue, that consolidated area. So it keeps on evolving, and so it is important to do serial ultrasound scans rather than one snapshot ultrasound of that particular area. Again, serial ultrasound is informative and allow us to track the changes, that is improving or worsening or how it is going. And color Doppler is instrumental in differentiating it from collapse or atelectasis. So we'll talk about the Doppler, the use of Doppler in identifying consolidation, the pneumonic or infective consolidation as opposed to atelectasis. Right. Again, talking about the evidence, it's not out, out in the thin air. So we do have evidence about it. So again, coming from the ASPNIC, POCUS is helpful, which is lung ultrasound is helpful to detect pneumonia in neonates and children. So there you go. If somebody asked you, so that's the level of quality of evidence we already talked about. And I have tried to put some papers in here. I'll share all the papers in the group, but there is n number of papers which talk about the same thing. from Cochrane to European Respiratory Journal and the neonatal journals with a good impact factors. So it is validated. Again, what are the signs in the pneumonia? So if you remember this air fluid curve ratio, you can imagine how the signs, as I said, it's a dynamic process, how the signs in ultrasonic signs will evolve with the mnemonic process. As you go down this route, where there will be less and less air and more fluid accumulation, to the point that you get to the point where there is a parapneumonic effusion, pleural effusion. So the signs will also eventually change. So what is the first thing that happens? Loss of aeration. So there will be alveolar and interstitial edema, because this is an infective process. When you have an infective process, the interleukin-6 are released, different tissue factors are released. There will be some hyperemia, what do you call this? Inflammation, leakage of the capillaries. So you'll end up with the alveolar and interstitial edema. It will lead to air and fluid bronchograms. Air bronchograms, yes, because that area will start collapsing. Fluid bronchograms, yes, because it's a hyperemic area. There will be fluid leakage, capillary leakage, leading to the fluid bronchograms, as it is an infective process. There will be a shred or a fractal sign, because as that process evolves, it becomes consolidated. By which I mean the air will be, there will be a loss of aeration in that particular area. It becomes more solid, filled with all the fluid in there. So you see a irregular consolidated margin, which is a shred or a fractal sign. Then there will be loss of pleural sliding. Yes, of course. How pleural sliding happens is when your visceral and parietal pleura moves. Now this area is consolidated, which means it is non-aerated. So it is not moving in with respiration like that. So it's quite solid. So it's not going to move. So loss of pleural sliding. Lung pulse. Now it's not moving on its own, but the heartbeat, it's going to make this impulse there. So you will see these T lines. The transmitted cardiac impulses will be seen when you interrogate that area with the M mode of the ultrasound. And increased vascularity over the consolidated areas. Here where the Dopplers becomes very instrumental. Now you can understand in lung is very peculiar or has a characteristic response to hypoxia as opposed to the rest of the organs in the body. So there is a thing called hypoxic vasoconstriction in lung. So when there is a hypoxia, your lung collapses. You're not aerating the lung, collapses. Atelectasis, collapse, non-aerated, but because there's a hypoxic vasoconstriction, you will not see increased vascularity in that area. Agree? So you will not see increased vascularity. You're not going to see a lot of Doppler flow there. Now take that as a consolidation in pneumonia. Infective process, all the interleukins released, this becomes inflamed. The vessels becomes dilated, and there will be more of a blood flow. We need more blood flow because that's a line of defense. You're going to get all the white cell, army coming in there. So the point I'm trying to make is because this is an inflammatory process, your vessels dilate, you have more of a blood flow, and that's what is picked up by the Doppler. And this differentiates consolidated pneumonic consolidations from other collapse or atelectasis. And we'll see example of that with the images. And eventually, because, inflammation, lot more blood flowing in there, capillary leakage, pleural effusion. Now it can be transudative or it can be exudative. Again, the difference is there. We're going to see that on the image. This is one of the, again, a diagnostic tree, done by Kurepa and colleagues. And I'm just trying to put it up here. There is, a couple of on the paper, but I'm trying to put it up here to show you that, how it progresses. And you start from lung sliding, you look at the A lines, you see all the signs. We're going to talk about it now. But this is a kind of a stem which we work on when we think about the pneumothorax or pneumonia or atelectasis or RDS or any lung pathology for that matter. Right. I'm sure you guys have seen this image. See this video on the last session. So bronchograms. Now, a lot of confusion about static and dynamic bronchograms. We do see bronchograms. Yes, there is a bronchogram. Is it static? Is it dynamic? To be honest, it's difficult to find out. I mean, is it a static or a dynamic bronchogram? Best way is to sort of zoom into the area and see if that bronchogram is moving, with the inspiration and expiration. Again, to explain it further, in atelectasis, which is a collapse of lung because that area is devoid of air, so there is no air trapping in that particular area. So there's no air movement going on in that area. There's air trapping, but there's no air movements going in that particular area. So that will give you a static bronchogram. Dynamic bronchogram is something. This particular consolidated area is not, collapsed because of it is devoid of air. It is collapsed because there's an infective process. It is becoming more solid by the fluids coming in. So it will try to move, which will give, when the baby is breathing, and it will give you a movement of your bronchograms there. So it will generate dynamic bronchogram. Also, because there is a fluid involved there, you will see anechoic areas. So that will be a fluid bronchogram. So if you see here with my cursor, these bright speckles here are all bronchograms, air bronchograms. Now, to be honest, I cannot figure out if it is a dynamic at all. To my eyes, it looks static bronchogram here. But you can see these areas. You can see these blackened areas, the anechoic areas, So these are the fluid bronchograms. So when you see fluid bronchogram, that is a giveaway, because atelectasis will never have a fluid bronchogram. It will always be an infective process. It will be a mnemonic consolidation, which will give you a fluid bronchogram, because there is no way that you're going to get a fluid and air tripping at the same time in atelectasis. That can only happen in the mnemonic process. At the same image, you can see a shred sign as well, because this is a consolidated areas. You can see these B lines are coming. You cannot make out any pleural line here. There is no pleural line, but you can see B lines coming up from these irregular margins. So that particular area is the consolidated area, shred sign. Right, also known as a fractal sign. And as I've said earlier, it is irregular border of the consolidated area. This is not a broken or irregular pleural line. It is not same thing. Again, talking about the shred sign, if you can see in this particular area here, there's an anechoic area, by which I mean it's lighter than this surrounding areas, which has white bright lines coming down, which are B lines, irregular margin, which is a shred sign, and there is an anechoic area. Now, how do I know this particular thing is an atelectasis? Because of low ventilatory settings or whatever reason, or is it a pneumonic process? So we have to interrogate that particular area with the Doppler. I'll talk about the tissue sign as well with the next image. We'll interrogate that area with the color Doppler. So the pulmonary arterial and venous vasculature is well demonstrated in the areas of consolidation. I have already explained why that happens. So if you see this particular area of consolidation, that's a solid area of consolidation. You can see the anechoic areas. There is a dynamic bronchograms there. These are fluid bronchograms coming in the picture. These are all moving. Sorry, I forgot to put the video on the loop. But you can see what I mean. So solid consolidated area with the fluid bronchogram, fluid anechoic on the ultrasound, and then the trapped air inside. So fluid and dynamic bronchograms there. And when you do a Doppler of it, So this is what you see, increased vascularity. You can see all the vessels coming up there. Not put on the loop. So if you have an increased vascularity, now the question is, how do we say it is increased vascularity or a normal vascularity? Practically, in a normal aerated lung, where there is, A profile or AB profile, you should not be able to see blood vessels because it are all are capillaries. You should not be able to see that. Whereas if you have consolidation, pneumonic consolidation, and it all dilates, if you are seeing any vessels, there, then that is called as increased vascularity. So if you ask me a number, how many vessels should we see? If you see even one vessels, showing up on a color Doppler, I will say that's increased vascularity. Because if you try to interrogate the normal area of the lung with a color Doppler, you will not see any blood vessel. You should not be able to see blood vessel in a normal, well-aerated lung. Again, so area of consolidation, oblique collapse or atelectasis. And then, do you see what I mean? So you see a big chunky vessel there going there. Any question till here?
Yeah, in collapse, so we should not see any increased vascularity.
In atelectasis sort of collapse, yeah.
Okay.
Yeah. Because, why the collapse happens or why the atelectasis happens is because there is no air. So if there is no air, the lung in that particular area is hypoxic. What is going to do? It's going to do hypoxic vasoconstriction. So when you have a vasoconstriction, are you going to see the vessels under Doppler study? Not really. But if you have a consolidation, vessels dilate.
Mm-hmm.
Makes
so
sense?
I have another query. Yeah. That makes perfect. So another query that both the areas of consolidation as well as atelectasis appears hypoechoic. So, and hypoechoic usually means increased in fluid content, right? So there should be fluid to be anechoic or slightly hypoechoic.
Yeah.
So why should collapse or atelectasis should have hypoechoic then areas?
Not necessarily. So now with the terms hypoechoic and anechoic, hypoechoic is relative. In ultrasound, it can be anechoic or it can be hyperechoic. So anechoic, black, hyperechoic, white. Anything in between is all relative. So it could be hypoechoic, the atelectatic area, to answer your question, the atelectatic area can appear hypoechoic. Now, hypoechoic compared to the, its adjacent area where there is a B lines. If there is a B line, there is adjacent area. Yeah, it's because there will be some amount of fluid anyway in the lung, isn't it? Because we see 2 to 3 B lines normally. So say suppose there is a athletic area and the nearby area is a normal lung, then the normal lung from where the B lines are projecting are hyperechoic, and the area just nearby to it, which is atelectatic, will appear hypoechoic to this hyperechoic area. It's relative. Okay. Now you can argue, can it be anechoic? Highly unlikely. It should not be anechoic.
Okay.
It should not be dark black. Yeah.
Okay.
Right. So the end of the spectrum for the pneumonia is when you get sympneumonic effusions, pleural effusions. Now, pleural effusions could be because of a pneumonia. It could be because of malaligned, malpositioned long lines central catheters. It could be because of very unlikely in neonatal population, but hemothorax. You can see that in pediatrics. But all that leads to pleural effusion. Again, any fluid is black. Blood is black when it is like immediate, but later on, blood becomes hyperechoic, like in CT scan in the head as well. So At initial onslaught, when there's a bleeding, it's black. Any fluid, black, but blood becomes whiter as it matures as the day progresses. So, so pneumonia will have exudative pleural effusion. There will be absence of a pleural sliding, understandably, because there's a consolidated area. There will be a quad sign. We have talked about all these signs. We'll recap those again with the images. There will be a sinusoidal sign with the M mode interrogation of the quad sign area. There will be a jellyfish, which is nothing but the lung flapping on the fluid is jellyfish. Curtain sign is again lung coming in the view and going away from the view is the curtain sign on the lung ultrasound. And again, lung ultrasound is very sensitive in detecting pleural effusion. It is more sensitive than chest X-ray because it can detect less than 5 mL of effusion, which is much more sensitive than the conventional chest X-ray, which needs around 100 to 150 mL of fluid to be detected. And this has sort of become a Bible for me now. So again, the recommendation point number 19 is lung ultrasound is helpful in detecting pleural effusion in neonates and children. So this is what the pleural effusion look like: anechoic, only fluid. So there is no tissue there. It's anechoic. That's your collapsed lung. And I'll show you the video of it as well. The flapping of the lung, the lung in the pleural effusion or the fluid is the jellyfish shine. And if you see here, this is your liver, and this is your lung. Just ignore the bright bronchograms here. The rest of it looks similar, isn't it? So ideally, the lung shouldn't look like this. So this is called hepatization, as in like it looks more like liver. And hepatization is also called as a tissue sign. It looks more like a tissue now. Yeah. So your liver and your lung looks similar. Okay. So so that's a tissue-like or hepatization sign. When you interrogate that area of pleural effusion with the M mode, then you see a sinusoid sign. Yeah. Sorry, if you are listening to a background noise of my little one, I apologize from my end. Right. So why the sinusoid sign is created? Now that's your subcutaneous or the soft tissue of the chest wall. So this particular area is a soft tissue, which you see here. And then your ultrasound waves goes through the fluid. So it appears anechoic, which is here. And then because your lungs are moving up and down in this pleural effusion. So inspiration, expiration, inspiration, expiration, inspiration, expiration gives you a sinusoidal sign. Quad sign again is nothing. It's you draw an imaginary line. That's the ribs and parietal pleura, visceral pleura. So that becomes a quad margin. So that's a quad sign. And you interrogate in this particular area with the M mode for the sinusoid sign. And again, the same thing. Those are the ribs coming in the picture as you're interrogating at the point of the rib, and inspiration and expiration going on. Anechoic dark black area, that's a fluid. This is your soft tissue of the chest, and that's a lung coming in the picture and going away, giving you a sinusoid sign. Curtain sign, so lung is absent. So expiration, so you only see fluid. Inspiration, lungs comes in, and it comes into the view, basically making the pocket of liquid look smaller. So that's a curtain sign. It's like a curtain. It comes and goes. It opens and closes. Jellyfish sign, again, we have talked about this. It's a flapping movement of the lung in the fluid. So you can see the tip is flapping about. So that's your jellyfish sign, like the tentacles of the jellyfish that moves when it swims. So that's what it is. Again, we can talk about the tissue sign as well. The lung looks same like a liver. So that's a tissue sign. Yeah. And right. So moving on, the spine sign, because ultrasound waves, loves fluid. It hates air, it loves fluid. So it goes, there is no or minimal attenuation of the wave, or minimal attenuation or absorption of the wave. So it goes, all the way to the end of the baby. So what you see when there's a pleural effusion, you can see the spine. So that's your spine coming in the picture. So that's a spine sign. Right. So what kind of an effusion it is, how you can determine that. So transudative effusions are always anechogenic and they are non-septated. You don't see a septate one. I had a beautiful video. Maybe I'll try to show it on a next one because I couldn't get it downloaded from my scanner, but I really want to share that with you people, where we have seen septated, exudative effusion with fibrinous strands hanging around, flapping around. Which will make it very clear for you guys to differentiate transudative. So what we have seen so far is transudative. You cannot see any strings or septas. So transudative effusion. In pneumonic process, it begins as a transudative. As I said, it is, it's a dynamic process. It begins as transudative, but eventually it might get converted to exudative one, where you can see complex non-septated, or I have a lovely video of which is a septated one, and it becomes echogenic. There will be a debris in the effusion which are very highly echogenic. Those are actually fibrin debris. And hemorrhagic, again, it becomes echogenic in the later, as the day progresses, as the blood matures. But initially, when it bleeds, at that point of time, if you're doing echo, it looks more like any other fluid, anechoic. Pulmonary hemorrhage. So I have kept it at the last, and I do not have a video to show you about the pulmonary hemorrhage. But again, I promise you that I'll show you a pulmonary hemorrhage because I have encountered only one where I have did a scan, of that particular baby. So the clinical context is the key. You're not going to see any specifics, any sign which is specific for pulmonary hemorrhage. Like there is no pathognomic sign which you see on a scan and you can say, oh, this baby has got a pulmonary hemorrhage. No, there is none. Because again, if you see or remember this air fluid curve ratio, when you bleed, when you bleed into your lung, you're basically filling up with a fluid. So, and then that blood will trigger the inflammatory process as well. So you can imagine you will have a broken pleural line. You can end up getting a consolidation because blood is a good culture medium. So you can have infective process there. You will, from the A lines, it will progress to B lines, compact B lines. It can start with subpulmonic consolidations and progresses to full-blown consolidations. So there is no particular sign which will tell you that this is pulmonary hemorrhage. So clinical context, the clinical background becomes the key here. Knowing the baby, is there is a added risk of a hemorrhage in this particular baby, large duct. Baby with a large duct and suddenly deteriorated. But there is no particular sign there. So it is mostly the clinical background which will guide you there, and hence it is not in the aspenic. So they haven't recommended lung ultrasound as a modality to diagnose pulmonary hemorrhage. What you can do with the lung ultrasound is you can track the progress You can see how the lung looks like. As I said, the blood is a good culture medium. There's always an added risk of a sepsis, consolidation, pneumonia. So you can track all those changes and by the serial ultrasound. But as a diagnostic modality, because when you bleed, it's going to come out from the ET tube anyway. So you're going to know that when you see that. So rather than diagnosing pulmonary hemorrhage, the ultrasound is instrumental in monitoring of the disease and tailoring your treatment accordingly. So papers have started coming out on the pulmonary hemorrhage as well, and I'm sure we will come up with permutations and combinations of signs in lung ultrasound to sort of indicate if you see this constellation of signs, maybe this indicates more towards the pulmonary hemorrhage. But as of now, there is none. There is no pathognomic sign there. So we do have studies which have started coming in. And hence I do not have many images or videos to share. I do have one which I will share with you in the upcoming sessions. I think that's it from the pulmonary hemorrhage perspective. We'll run through some practice slides now. I'm mindful of the time as well, but we'll quickly go through this. And feel free to come in and comment. Right, if anyone wants to comment in this particular video here.
Okay, I can give it a go.
Yeah, go for it, Doris.
So I can see the pleural.
Yeah.
Sliding.
Yeah.
I can also see some subpleural consolidation.
Mm-hmm.
Okay. And then I can see lots of B lines.
Yeah.
And I think some comet tails. So I can think some faint, I saw some A lines. I think those were A lines, but I think I would say this is predominantly a B profile.
Yeah. Do you want to comment on this particular area?
Yeah, I was pointing at that. Like it looks quite irregular. Is it subpleural consolidation? This area, is that subpleural consolidation?
Mm-hmm. Mm-hmm. Okay.
Is there a straight sign?
So it is a stretch sign, yes. So it is a stretch sign. So that's the area of consolidation here. Again, collapse oblique consolidation. So I'm not committing at this point of time if that is a area of a pneumonic consolidation. So I can see, and again to sort of stress here, Mayank. So what I meant by hypoechoic being relative. So if you see all these white lines, these are very bright. But if you go and focus in this particular area, it looks a bit, hypoechoic compared to the rest of the area here. If you see what I mean.
Yeah.
So this is not anechoic. It is not like this. It is not like black like this, but it is hypoechoic, compared to the rest of the B lines coming up from the lung. So broken pleura, yes, and there is a shred sign here, which is not pleura, which is a irregular margin of the consolidated area. Now let's interrogate that with the M. Yeah.
Are there some air as well as fluid bronchogram?
There is, sorry?
Are there some fluid as well as air bronchograms in that?
So there is an air bronchogram. Yes, there is an air bronchogram. And fluid bronchogram, I can't really say there is a fluid bronchogram here at the moment. If you're referring to this particular area, sorry. If you're referring to this particular area here.
No, slightly onto the left when it moves. Yeah, like that.
So this particular area?
You fluid.
On the left.
On the left here.
Yeah, somewhere there.
Right. Okay. So let's see how it looks in the color Doppler.
Sure.
Anybody wants to comment on that?
There is no vascularity on this one. We don't see any increased vascularity.
Yes. So this is not a fluid bronchogram here, to answer your question. That's an area of, small segment of the lung which has collapsed, atelectatic at this point of time here, and same goes here as well. So,
thank you.
If you just look at it, you might feel like, oh, that's an area of consolidation, Schredt sign, pneumonia. So before you commit yourself that this is a consolidated area with pneumonia, always do a color Doppler, and it will give you the answer. Yeah, makes sense.
Yes.
Sorry, I'm not entirely clear. So there is no increased vascularity. So what does this mean? Is this consolidation or atelectasis?
Atelectasis.
So this is actually because there is no increased vascularity. Okay.
Yes. Because if it has to be a infective process leading to consolidation, then I would expect there to be increase in vascularity there.
So is that still a Schredt sign? Because I thought Schredt sign was when there's consolidation.
I had the same question.
Yes. Again, these terms are so used I don't know how to say this. That's why I always say collapse / consolidation. So the Schredt sign can be, as I said, how do I put it? So it is an irregular margin. So when you have an atelectatic collapse, again it's a collapse, you can have an irregular margin there. Okay, so you can get a Schredt sign there. You can get a fractal sign there. It is irregular margin of that collapsed area. Collapse consolidation. So I always use the word collapse / consolidation. Unless you do a Doppler and see that there is an increased or no increase in vascularity, you can never be sure that is that area is consolidated, infective consolidation or not. Are you getting me, or am I making you guys more confused?
Thank you. Makes sense. Yeah.
It's very clear. Can I ask now? Sorry, Abhijit, about blood, like Doppler.
Yes, Sharif, your voice is breaking up.
Sorry, would you describe that as a Doppler, like increased vascularity?
Sharif, I didn't get the first part of your question. Can you repeat again?
In that Doppler, do you consider, if you play the video, do you consider that as increased vascularity?
On this particular one, no.
This one?
This one, no. You can't see vessels coming up there.
Fine, thank you.
Yeah. Anybody wants to comment on this?
Can I?
Yes, go for it.
Diagnosis or description?
I would say description.
So the blue line is not clearly defined. It's like blurred.
Yes.
And there is probably an area of which is anechoic area, just where the blue line is being broken down, and there is also a movement of this piece of pleura in and out, or maybe lung tissue. This is very much similar to the sign that you've shown us earlier, when there was a pleural effusion, where there is a curtain and there's a jellyfish sign.
Can I come in, Jaruddin? So again, I haven't put this slide to confuse you guys. I have put this slide to I have put this slide to show you the difference of different consolidations, collapse consolidations. So here, now this particular baby has got RDS. Now rib, rib, rib. I can't see acoustic shadow because there's a compact B lines. Yes, you're right. We cannot see a very bright, discrete, regular pleural line. Rather, it's a smudging effect. And these are the subpulmonic consolidations. I have zoomed in here. So this is how it looks. I cannot see any A lines whatsoever. It's all compact B lines. Yeah. So again, this is not lung moving in the pleural effusion because I can't see any effusion here. Subcutaneous, not subcutaneous, soft tissue. So that's your soft tissue, ribs, yeah, and that's your pleural line. So there is no fluid here, and these are all the subpulmonic consolidations, and this is the area of acoustic shadowing, and this is subpulmonic consolidation, and all the B lines, compact B lines. So this is RDS. Now again, this is subpulmonic consolidation. You don't see shred sign there because these are micro consolidations or atelectasis or collapse, however you want to name that. So it's a small, minute collapse of the lung in the RDS. So this is a classical subpulmonic consolidation in RDS.
So
Happy?
we do not call that shred sign, right? Because it's smaller.
No. This is not a shred sign. No.
Okay.
Yeah. Next one. Who wants to come in?
May I?
Yeah. Go for it.
This seems to be a double lung point. The cranial part is well aerated, while the caudal part seems to be a little wet. So this is a double lung point for me.
Excellent. Again, not to confuse you guys, this is just as a recap. As I said, we'll do it in a slightly different manner. So yeah, bright, sharp pleural line, and you can see smudging of the pleural line there, if you know what I mean. So that's smudging. You cannot make out pleural line very discreetly here. So it's all B lines, compact B lines here. Here, it's bright and discrete. And then you have some A lines, lung rockets coming in here. A lines you can see here. This A lines continue still here. And because you have B lines coming, this A lines get obliterated. You don't see A lines in that particular area. So B line always obliterates or abolish A lines. So this is a classic of double lung point. And you can see this commonly in TTNB, but you can see this in RDS as well when the baby is post-surfactant, when baby is improving. Basically, again, air fluid ratio, if you see, air fluid curve, if you see. So it is self-explanatory. As the aeration improves, from a RDS state, some areas will get improved earlier than the other. You can see double lung point. In TTNB, that's the pathology. It's a fluid-filled lung, but it's patchy and non-homogeneous, unlike the RDS. So you can see some well aerated and some loaded lung, and hence the double lung point. Right. Anybody on this one?
Can you go for it?
Yeah.
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 Yeah. It's a normal lung.
Excellent. If you want to describe the video a bit.
Sure. It's a straight, clear pleural line, comet lines, and you could see A lines.
Yes. Excellent. So why I have put this slide again is because to show you how the lung rockets looks different from a B line. So if you see, these are the lung rockets. It is not reaching the end of the screen, and it is not obliterating the A lines. So these are the small lung rockets coming. It also aids you in sort of differentiating or is telling you that there is a pleural sliding going on there. So those are the lung rockets not erasing the A lines and not reaching all the way to the bottom of the screen. Hence, it is not a B line.
Can I add? Is there a
yep.
truck sign or a mirror image?
Excellent. Let me go back to it and undo that. Right. So so this is a mirror image reflection of the ribs here. You're absolutely right. This is a truck sign. So if you see a truck sign without the B lines or the lung rockets, you think of pneumothorax. Excellent. Yeah.
Just one question about the previous slide. You see the lower part dark. So here, if I change my frequency, decrease my frequency, will it be clearer for me? In the lower part.
It should make it clear. Yeah. Yeah.
Okay. Thank you.
Yeah. Guys, can you hear me?
Yes.
Yeah. Yeah.
Yes.
Okay. Yeah. Right. Anybody wants to comment on this particular slide?
Yeah, give it a go. So I can pleural.
Yeah.
Regular. Apart from this middle area, just right here. Whether I can call that a shred sign.
Yes.
Okay.
Beautiful.
Yep.
Yeah.
Pleural sliding.
Mm-hmm.
Yeah. And can see B lines here, Crowley's B lines, and on the left side of my screen, I think these are A lines.
Sorry, it's moved. Yeah, is it Doris who is speaking?
Yes, yes.
Yeah, Doris, when we see consolidation, again, to make it clear to the group, when we're talking of consolidation, when you can already see consolidation, then we don't necessarily have to talk about the sliding at that point of time. Yeah, because if you're seeing the consolidation, you know there is a lung which is consolidated, isn't it? So, basically, if there is a consolidation, there is a lung there. So when we talk about the the pleural sliding from the perspective that is there a visceral pleura there or not, that's the whole idea. Yeah, just to make sure that there is a lung there. So if it is sliding, we know that is a lung, which is the visceral pleura is sliding. If there's a consolidation, there is a lung which is consolidated. So once you say that there's a stretch sign or there's a consolidation, we can assume that there will be a pleural sliding. There might not be pleural sliding, but that will not it will not indicate towards the pneumothorax or anything else, because there is a consolidation already. Okay. Make sense?
Yeah. Can I ask, is there a double long point here? Because on the left of the screen, I can see A lines.
Mm-hmm.
And then here is at this B lines. So can you call this? I don't know.
I mean, if you strictly go by the image, yes, you can call it. But right now we are trying to deal with the consolidation in this particular case, as in like in this particular baby. So, so you can see, double lung points in a TTN baby and who has, developed an infective focus at some point, some part of the lung. So yes. This is not the best slide to comment, on the lung sliding, given that because this baby is moving a lot and, we're trying to capture that particular area. But if you can see, this is nicely, one area is well aerated and the other one is having a lot of B lines. Then you can comment on double lung point. But here what we can see is one area is well aerated. That's fine. The other one we are seeing is only the consolidated area, isn't it? We don't know how the rest of the lung looks like.
Yeah.
So this might be a baby who has, absolutely normal lung otherwise, and has got pneumonia and is having, consolidation in that part. And when you have consolidation, you're going to see a lot of B lines because there is fluid. Yeah. So I will. Yeah.
What is this broad vertical acoustic shadow coming in the center?
You mean this one?
I think below that.
Is that this one you're talking about here?
No, to the left.
Here?
No, the dark shadow just coming in the center. Vertically.
Vertically. Is that this one you're talking about?
No, the other one.
There.
This one. Yeah.
This one.
Right.
Right. Okay, that's your acoustic shadowing. So if you see, that's your rib there, and none of the ultrasound waves are coming here. So to the scanner, it looks like there is nothing because all your waves are going back. Yeah.
Compared to the other rib, it's looking quite broad. That's why I got a little confused.
Okay. No, that's a rib only. Yeah, that's a rib only.
Thank you.
Again, we're gonna interrogate that area with the Doppler. Do you see vessels?
Yes.
Yes, some vessels.
Yes. What do you think that is then?
Consolidation, no?
Absolutely. Because now you can see that the lung otherwise looks okay in the other segments as well. There is some B lines, but you can see A lines even in these areas. The B lines comes up, but there are A lines. But this particular area is the area of interest where there's a consolidation, and it looks to me like there is some kind of a pneumonia going on there. Yeah.
Abhijit, can I ask you a quick question? Sorry.
Yes, please.
In RDS, it's very common to see subpleural consolidation. Okay.
Yes.
And if we put the Doppler on that, are we expecting to find increased vascularity? And then
no.
Okay, that makes sense because that will differentiate between pneumonia and.
Yeah. So the subpulmonic consolidations, if you're going to apply color Doppler on that, you're not going to see anything. No vessels.
Okay.
Yeah.
Thank you.
No worries. This one, it's a sort of a giveaway, isn't it?
Can I comment?
Yeah. Yes, please. Go ahead.
I think we see an hypoechoic area with a shred sign in the right of the screen and multiple B lines on the left of the screen. Yeah. Absolutely. I think we have air bronchograms also.
Yes. And those are dynamic.
Hypoechoic area.
Yeah.
And the blood.
So
increased vascularity.
Pneumonia.
Yeah.
Excellent. I know you all know this now. No pleural sliding. Bamboo spine, no pleural sliding. I can't see lung rockets, B lines, pneumothorax.
If we can get a NAM modes, that would even be better.
Absolutely. So as I said, the more and more you see, you will start recognizing the pattern. And Doris, here I would say this is anybody. We have seen this slide, I think, already. This is a lung point, aerated. Yeah, lung point, absolutely. Right. Again, I'm not good in X-ray. So I did an X-ray. This is a very recent case. And I apologize because I don't have a very good video, because I made a video out of a video, but nonetheless, we can get all the information on that. But anybody wants to comment on this particular X-ray? What do you think, basically? You don't have to describe it, but elephant in the room.
Right upper lobe collapse.
Yay, absolutely. Excellent. So that's what we thought.
It's or consolidation, no?
Or consolidation. Why not? That's what we thought. And we approached with the scanner. And this is what it looks like. So R1. Okay, I will not take a lot of time, so I'll tell you. Apologize for the poor quality of the video because it's a video of the video. But where is the collapse? I don't see any collapse here. Do you? I can see mirror image, rib, and ribs comes up here, comes up here, comes up here. And then I see nice A lines. Yeah. Maybe occasional B lines, but nothing like collapse here. Agree?
Yes. It's not a pleural effusion on the right, on the left.
Here you have your answer. So again, we are still in the R1. So I tilted my probe trying to find where that thing gone. It looks solid in the X-ray, but I can't find it on the lung ultrasound. So I tilted my probe a bit. So you can see hard. I'm still on the right side, but I've sort of tilted it, try to find this collapse oblique consolidation atelectasis, whatever. And I see this. Any comment? What is this?
Thymus?
Absolutely. So there you go. When we did that X-ray, and there was a lot of buzz and a discussion about, that baby was ventilated. You can see the ET tube there, quite high up. But it was like, the tube is high. We should push it in. I'll go back to the chest X-ray. Yeah, so tube is high. We should be putting it down a bit because there might be an area of collapse there. So we should be doing right side up nursing, some physiotherapy and whatnot. I mean, that's the most logical thing. We always have done that, and we always do that based on this X-ray. Now, I wanted to do a lung ultrasound and see for myself, like, what exactly is that? Because it could be either atelectasis because the tube is high up and it's not getting well aerated, one of the reason, or it could be a consolidation pneumonic process, which is most of the time somewhere here. Most of the time it should be somewhere here, as we have seen in cases, but it is here. But it can happen there as well. So, or maybe it is not draining properly, so we need more of physiotherapy, so it has collapsed or something. So when I did an ultrasound, and it gives us an answer, voila. So that is thymus. So what do you do about it? Nothing. Let the baby at rest in peace. Right. Anybody wants to comment on this one?
Shall I?
Yeah.
So this is just pleural effusion mainly, and I think this is the lung margin, which is giving an undulating appearance, moving back and forth.
Yeah. Brilliant. So that's your pleural effusion there. That's a pleural effusion, and your visceral pleura has come down here. So from here, you're getting all your B waves coming down. Those are your ribs, and that's a pocket of fluid there. Looks like transitive at this point of time. Lovely. And you can see some A lines also. Anybody wants to comment on this? It's a bit tricky. I'm not trying to have fun, but I can't stop myself. This will be covered in upcoming sessions. So,
pleural effusion with sine wave, sine.
Yes. No, Leila. So exactly, this is my point of putting this here.
Okay.
To show you
mirror image.
Diaphragm. This is the diaphragm.
This is the diaphragm. Absolutely.
Okay.
Yeah.
So why there's a tissue-like thing below the diaphragm?
I'll come to that. So the reason why I have put it here is to show you how different it looks, a pleural effusion, when we are trying to compare it with the diaphragmatic excursion. So lung ultrasound is also used to sort of see the diaphragmatic excursion for various reasons. I'll not go into the details of that. It will be covered by one of our speaker. So I'll not go into that. The point I'm trying to make here is to show you the difference, how different it looks. So, so this is your liver, this is your diaphragm, and we have done the M mode interrogation of that area. So to see how the diaphragm is, moving up and down. So any up and down movement in an M mode, as we have seen in pleural effusion, it will give you a sinusoid sign. So this is with inspiration, the diaphragm is, coming down, and with expiration, the diaphragm is going up. So it gives you a sinusoid sign. The difference from the pleural effusion here is, so because your M mode interrogation is through the liver and there is no fluid, you don't see anechoic black color. Okay. That's how it looks in pleural effusion. So this is the anechoic area, which is pleural effusion. So it looks black. And that's your undulation of the lung with inspiration and expiration. Looks like a sinusoid sign. But whereas when you do a diaphragmatic excursion, it looks like this.
In the thymus slide, was there a pleural effusion or just air we see? The slide you showed on the thymus.
Sorry, Laila, can you repeat yourself again?
The slide of the thymus. You could see a dark aquatic area. That's fluid or just air we see?
On the thymus?
Yes.
This one?
Yes. So what we see?
No, we are not seeing fluid. And again, because this is a video of the video, it looks a bit weird in terms of, the gain and the how bright or dark it looks here. But trust me, it looks like a tissue, like you see the liver. It looks exactly like that. It looks like a solid tissue. The way it is looking here is because it's a video of a video. Yeah, because I couldn't download the images. If next time if I can, I'll definitely show you the one which you have acquired on the scanner.
Thank you.
Okay. Right. So, right. I think this is in terms of sessions or lecture. This is my last one. I'll be with you guys in terms of reviewing the images. But the idea is, with the POCUS, not only the lung ultrasound, with the entire POCUS thing, the point of care ultrasound, we have to, incorporate this technology as an extension of the senses. We as a doctors, we have always used our stethoscope, as an extension of our senses. We always listen to different pathologies, be it the chest, heart, or abdomen. And I think the time has come where that needs to be, I would not say replaced, but aided by the stethoscope to give you more information. People ask me, in my unit also, as in all the units, there will be some for the modality and some, I would not say against, but skeptical about the modality. And the question I always face is like, what changes when you do a lung ultrasound? How it changes management. And the answer to that is like, maybe nothing. It doesn't changes anything. Like how many chest x-rays you do changes management? It doesn't, you have a pleural effusion, baby CRP has rose, baby is septic, you have done, or you have seen, some sort of a fluffy opacities or consolidation on a chest x-ray. What do? You don't do anything. I mean, you just continue with the antibiotics and the care, but that there is a focus in the lung. So, maybe slightly longer days of antibiotics and stuff like that. So the lung ultrasound is also same thing. It gives you more information. It gives you more information to make more informed decision in tailoring the treatment of the baby. So, so to answer to that question is like, yeah, it might not change anything, but it gives you more information maybe not to act on it, rather not to do anything about it. Most of the times we go and do too many things with the baby. Sometimes we don't have to, like I showed you in the case of the thymus. So did it, have we done anything, in terms of management with that baby? No, we haven't done anything, because we know we don't have to do anything, because now we have more information that that particular area is just a thymus, and you can just ignore it and let the baby, be at peace. So yeah. So most of the time you might not change the management. Well, almost most of the time, and some of the time it makes a huge impact on making decisions about the surfactant and stuff like that. But yeah, that's the idea. It should be the extension of our senses and should be used on a regular basis more frequently. And I think that's the end of it. Keep calm and scan on.
I think an excellent session from Abhijit. And to kind of say that, again, just an additional point to answer the question of people who say, well, what does a lung ultrasound add? The fact is we get hundreds and hundreds of x-rays, which often don't change management. Not only they give additional handling to the baby, they also give radiation. And, from our perspective, a lung ultrasound, needs to be viewed very much with the same level of, I would say, candor, in that if an X-ray is not going to change our management in a particular situation, why are we getting one done? In particular, if we can do a lung ultrasound, which is going to give zero radiation, and it can be finished in a minute, for the relevant areas. So I think, fantastic talk, and just again, to kind of emphasize, so you've seen a lot of lovely, beautiful images that Abhijit has shown us today. So as part of your exam sessions, I mean, a degree of pattern recognition and recognition of some of the images with clinical correlation will be some of the questions. So, it's a brilliant kind of a way to kind of give you an idea of what kind of questions you'll get when you have to complete your final kind of assignment, which is the MCQ. I'd like to thank you, Abhijit. God bless you. Thank you so much. And I look forward to seeing you tomorrow.
Lovely.
Thank you, everyone.
Thank you, everyone. Thank you for patiently listening. Thank you.
Bye.
Thank you. Bye.